Good morning, everyone. Again, this is Rebecca Vickers with the Florida Alcohol and Drug Abuse Association. We are going to be getting started in about 5 minutes, so now's a great time to get yourself all ready to start the presentation at 10 o'clock. Thanks. Good morning, everyone. I'm Rebecca Vickers, and on behalf of the Florida Alcohol and Drug Abuse Association, welcome to today's webinar entitled Trauma Resolutions is Relapse Prevention with Susie Kowalsky. This webinar is being made available through a collaboration of the Florida Department of Children and Families Office of Substance Abuse and Mental Health and the Florida Alcohol and Drug Abuse Association. Please note that as an attendee, you are in listen-only mode and will only be able to view your name. If you have questions, please send them to the presenter and me, the host, by using the chat panel. The button to open the panel is usually located on the upper right side of your monitor. Please use the chat panel to send any questions you may have as you think of them. The presenter will address questions as time permits. Our audio is broadcast through the internet to your computer. If you experience poor computer audio, there are a few options to try on screen right now, and these options are posted in the chat panel too. If you continue to experience poor audio through your computer, try rejoining the webinar and call in using the telephone I will call in option. You must be connected to the audio of this presentation and view it on screen as well to receive a certification of attendance. The recording and materials used in today's presentation will be available on the FATA website within 30 business days. To access the recording and PowerPoint, go to www.fata.org to the Resource Center and then Training Library. FATA produces many webinars and workshops through the support of the Florida Department of Children and Families. To help participants track credits earned through attendance, we host an online community that provides a personalized digital journal where participants can maintain statements of credit for webinars and workshops taken through the Florida Alcohol and Drug Abuse Association. At the end of today's webinar, the web browser will direct everyone to an evaluation form on the FATA's website. You will first need to register or sign in to your account to complete the evaluation. Information you provide FATA as a part of registration remains confidential. Statements of credit will be posted within 5 business days after the evaluation closes in individual professional development journals for persons completing the evaluation and attending the full webinar. Completing the evaluation is necessary to receive CE credits or to access your statement of credit. Do note that the evaluation will close at midnight on Tuesday, April the 12th, 2021. 1 to 2 continuing education credits are available for participating in today's webinar for persons licensed through the Board of Nursing, the Board of Clinical Social Work, Marriage, Family, and Therapy, and Mental Health Counseling, and for persons credentialed through the Florida Certification Board. If you are a licensed healthcare practitioner, be sure to include your Florida license number for reporting to CE Broker when you register with our site for the first time. If you are certified with the Florida Certification Board or licensed outside of the state of Florida, you do not need to provide your certification number when you register with our site. Note that WebEx monitors arrival and departure of attendees and provides a report upon completion of the event. We are not permitted to provide contact hours or a certification of attendance if you do not attend the entire webinar. We are not permitted to provide partial credit. Susie Kowalsky has been serving stigmatized communities for more than a decade through direct clinical practice, as well as by delivering training and consultation to students, service providers, and administrators. Susie has worked in a community mental health organizations in Chicago to develop and implement new programs, combining her clinical expertise with administrative and organizational skills to launch trauma-informed programs based on principles of harm reduction. Susie applies her experiences as an outreach worker, substance use counselor, trauma therapist, clinical supervisor, and program manager to develop trainings for a broad range of workers with different roles, experiences, and expertise. As a therapist, clinical supervisor, trainer, and consultant, Susie emphasizes a relational approach in which healthy connections facilitate the development of insight, practice of new skills, and curiosity for continued growth. And now I welcome our presenter, Susie.
Hi, good morning. Thank you, Rebecca, for that warm introduction, and to Karina and Eric as well for all of your behind-the-scenes work to make this webinar happen today. I also want to thank the Florida Department of Children and Families and FADA for bringing me in for this webinar. It's always such a pleasure to work with all of you, so I'm happy to be back. And then to all of the attendees, thank you for taking the time out of your busy schedules. I think it's such an important part of our professional development and maintenance to really make time to attend these types of training events. So I'm glad that we're here together this morning. A little bit about me. I work, as Rebecca said, in Chicago, and I run a training and consultation business with my husband, James Kowalsky, who you all have probably also seen on some of these FADA events. And so here's our contact information. If you have any questions that come up, certainly feel free to ask them throughout our time together this morning, but if something occurs to you after the fact, or there's like a specific resource or something that you want to troubleshoot, please feel free to reach out. It's always nice to hear from people, and I'm always happy to be a resource to the folks who are doing this really important work. There are no actual or potential conflicts of interest to disclose. This presentation was created without any commercial support, but still important to just take note of that. So in our time together today, this is a really big topic. I want to say I'm really excited for this topic. I would say that working around trauma and substance use, and then kind of at the intersection of where these two topics meet, is really kind of the heart of my professional passion. So this is a topic that I'm thrilled to be talking with you all about, and that I would say I've been studying for at least 10 years. And so we're not going to cram all of that information into 2 hours. So we'll kind of hit on some of the key points along the way. So we'll start out by looking at, like I said, kind of that intersection of where traumatic events and substance use disorders overlap, and think about how they affect and influence one another and what recovery looks like, thinking in this kind of integrated way, that we're not addressing just one or the other, but that these are issues that kind of come together and form their own separate thing. We'll talk through really important principles for practicing trauma-informed care when working with people who have these co-occurring needs. And then we'll wrap up by thinking about some really innovative and integrated approaches to recovery for people who've experienced both a history of trauma and substance use disorder. And I will say integration is something that you're going to hear me talk about a lot today, because that is really kind of the goal. Is we want to challenge ourselves and our program and really the field to move beyond this siloed approach where, we have treatment and kind of a set of skills and the way we think about working with people with substance use disorders, and then a separate set of skills for people who've experienced trauma. We know that these two things tend to go hand in hand so often, and so we want to be able to treat them together, like I said, in a really integrated way. So that's kind of our roadmap for the day. So we know that trauma and substance use disorders share a lot of common ground. And, I think sometimes we have this question of like, which came first, the substance use or the trauma? Did one lead to the other? How do we separate them out? And that's like a really complicated and layered question. But what I will say is we don't necessarily have to know which came first. What we do need to know is that these two things are present together, and we want to develop a really nuanced understanding of how these two factors tend to influence each other. And, you know, sometimes the people that we're working with may not even have an understanding of that themselves. So that's part of our exploration with people is, you know, learning alongside them what this interaction looks like. But we definitely need to understand how their trauma and their substance use interact with each other, because I think in this field we tend to be really great at having strategies for supporting people in learning coping skills to manage their substance use, implementing relapse prevention plans, and being able to address different behavioral concerns. And if someone's trauma history is related to their substance use, then it's also going to be related to their recovery. So relapse prevention skills that don't take into account the influence of trauma aren't going to be sufficient. Yes, they're very important on their own, absolutely, but it's an incomplete set of tools if it doesn't also take a look at how someone's trauma history is related to their use and to their recovery. So I wanted to start out with a survey and just get a sense from you all. What percentage of the people in your program do you think have experienced some type of trauma? So you should see the poll pop up there, and A is less than a quarter of them, B would be about 25 to 50%, C is 50 to 75%, D would be more than 3/4 of the people you serve, or E means you're really not sure. And obviously, you know, you may not have like hard data, but just kind of anecdotally in your experience, what would you guess as far as where people in your program fall in terms of what percentage of them have experienced some type of trauma? So I'll go ahead and give you a minute to fill in the poll. I apologize if you're hearing the dog next door. He barks all day, so you're hearing a little bit of the soundtrack of my life. All right, so I'll go ahead and give people another 15 seconds to enter your response. Okay, and Rebecca and Karina, if you can go ahead and close the poll, we'll see where people's responses fall. Okay, so thank you all for responding. We have a really clear front runner here of more than 75%. So the vast majority of you are saying that more than 75% of the folks in your programs are, you would guess, have experienced trauma. So yeah, but thank you for that. And then a couple of you said less, 25 to 50%, and a few of you weren't sure, but almost half of the respondents are saying more than 75%. And I will say that in my experience, that's my experience as well. the vast majority of people who we tend to see in treatment programs have experienced some type of trauma. So we know that these are the folks that we're seeing in our programs. There's, again, not this kind of siloed place where people who've experienced trauma and have a substance use disorder go to one treatment program and other folks go to another. These are a lot of the folks that we're already seeing in our program. And the data really supports what we already anecdotally know to be true and what you all are showing in the poll, which is that there's a lot of overlap between substance use disorders and trauma. And we know that trauma exposure is a really significant risk factor for future substance use disorder. So we see that teens who have a history of physical or sexual abuse are 3 times as likely to have current or past substance use. More than half of adolescents with PTSD develop problems with their substance use, and 70% of adolescents who are already in treatment programs have a history of trauma exposure. And I think that one is actually a very significant thing for us to think about. But we know that for people, especially young people, but I would say also this is certainly true for adults, that when people have experienced trauma and complex trauma, which when I say complex trauma, I mean ongoing interpersonal trauma that begins in childhood and really kind of characterizes someone's experience of growing up and their development, a lot of folks use substances as a way to cope with their experience of trauma. And a lot of that is because, by definition, trauma is a really dysregulating experience. It overwhelms our capacity for coping. And so people need to find something to help regulate and soothe our systems. And so very often for people, what that ends up being is substance use. And then we will talk through these ideas some more on the next 3 slides, but we also know that substance use itself is a risk pattern or is a risk factor for traumatic events. And so we see this cyclical pattern play out. So there are a lot of studies that have shown that there's a really significant link between adolescent alcohol use and engaging in risky behaviors. So adolescents who are using alcohol are more likely to do things like hitchhike, walk through unsafe neighborhoods, drive while intoxicated. And so we can see where substance use is increasing people's engagement in risky behaviors, which then puts them at a risk for re-traumatization. We also know that people who have severe substance use disorders have a hard time being able to discern between safety and danger. And we'll talk through why that is a little bit more. But again, these first 2 factors combined really increase the risk that someone who has experienced trauma and is using substances will experience subsequent traumas, and then we see that cyclical pattern kind of play out. As far as inhibiting the ability to cope with traumatic events, I know that I don't need to tell you all that we see, especially among people who have a really severe substance use disorder, that they may experience some functional impairments associated with their substance use, which then in turn really kind of limits their ability to cope with traumatic events in ways that tend to be healthy and more likely to be healing. So there's one study I thought was really interesting where researchers found that even when they controlled for trauma exposure, adolescents who had a substance use disorder were twice as likely to develop PTSD after traumatic events than their peers who were not using substances. So we know that substance use disorders increase the likelihood of exposure to trauma and at the same time can really inhibit a person's ability to manage the effects of trauma. So let's dive into why that might be the case. So with trauma survivors, we often see a pattern of coping by taking risks. And there's a few reasons that happens. So trauma is something that begins in the body, and it makes it really difficult for folks who've experienced trauma to regulate their bodily functions. And because of that, they often then end up using external stimuli, things like substances or other risky behaviors, to regulate their internal experiences. So substances become a way to cope with the symptoms of trauma. So, for example, I've worked with many people who experience a lot of really intrusive memories and like intrusive thoughts, where thoughts, the memories about the trauma sort of are encroaching on them, and they don't want to be thinking about their trauma all day, and it's really interfering with their ability to function. And I've worked with many people who avoid those intrusive thoughts by using substances and kind of push those things out by turning it down. I think one of the important things for us to keep in mind is that people aren't engaging in these behaviors in order to take risks. They're not seeking out risky behaviors. They're seeking out something that will soothe their dysregulated body and brain as a result of their experiences of trauma. In terms of risky behaviors being adaptive, one of the other things that I hear very frequently from trauma survivors is that just knowing what they know and feeling what they feel is excruciatingly painful for people. And so they use substances or self-injury or gambling or forms of violence, other risky behaviors to kind of block out this unbearable knowledge and to have a little distance between their knowledge of what has occurred. And so I think another way we can really reframe risky behaviors is that they're also a way for people to take control, albeit in ways that may not be particularly effective, but we can understand where someone who has experienced so much trauma, which is so characterized by not having enough control, we could understand why someone might want to try and find some type of control in areas for their life. We know that trauma impacts people's ability to think long-term and to connect their current behaviors to any kind of future plan and goal. I think actually a really good example that we can all relate to is the effects of COVID that we have all been experiencing, and for, really the past year and more. For most of us, our focus day to day is just getting through like the next little period of time or the next wave of whatever's occurring in our area. And it's really hard for us to think about the future and make realistic plans, right? If you ask someone last summer, like what their goals are for early 2021, it's like, I don't know. Like, I can't even think about what's going to be happening then. It's so hard for me to like picture a future, let alone like make goals and try and take steps toward that. So that's a lot of what happens for people when they've experienced trauma, is that it's really hard to think about the future and make realistic plans for it when everything in the present feels really up in the air and unstable. And as far as like dissociation, one of the key features of traumatic wounds is the sense of really flip-flopping between feeling flooded and hypervigilant and very much on guard, with the opposite extreme where we're feeling numb and not present and dissociated, and where everything feels sort of muted. And a lot of trauma survivors talk about the incredible discomfort of feeling so numb, even though it is a protective mechanism. And so folks then engage in behaviors that activate their body and brain to feel some kind of a rush. And it just like reminds people that they're still alive and still capable of feeling something. And because people's experiences are so muted or dampened, we often see patterns where they then require increasing and escalating levels of risk in order to feel anything. They essentially develop like a tolerance to risk, so to speak. So again, I think it's important for us as providers to really reframe risky behaviors and to understand that people don't set out to be reckless and to put themselves in danger. Instead, I think it's helpful and more trauma-informed for us to view people as really doing everything that their traumatized bodies and brains can do in order to survive overwhelming threats. So trauma impairs our ability to know when we're safe and to know when we're in danger. Essentially what happens is that when we're threatened, there's an alarm that goes off. That threat ends, but the alarm doesn't stop ringing. It's still going. And because people live with alarm bells that are always ringing, for one, they learn to tune them out. But more importantly, those alarms are no longer a useful source of information, right? You don't know, is there actually some kind of danger, or is the alarm just going off because it's always going off? And so the sense of alarm fatigue, as I'm referring to it here, is part of what leads to increased risk of being in dangerous situations where someone's alarm might be going off, but like it's always going off, so they don't know, am I actually in danger or am I feeling safe? I think one of the best descriptions I've heard from a client about what this feels like, so someone who I worked with for a long time who was talking about walking through like this abandoned parking lot alone late at night, and she had like a pattern of doing this because that's where she parked for her night class. And when we were talking about, you know, is this safe? Is this dangerous? What do you think? What she said to me is, Susie, I never feel safe. So how would I know if I'm in danger? And that has always stuck with me as like, this is what we talk about as like alarm fatigue come to life. We also see that people who have a trauma history have a distorted sense of safety. So people may feel safe when they're actually in danger. So they kind of like miss or misinterpret cues for danger. And then on the flip side, we also see that folks feel like they're in danger when they're actually safe, because we know safety is very subjective. And so we see people, and you all probably see it in your programs quite a bit, who are responding to safe situations, like, for example, receiving services with us, as if they're in danger. And there's some interesting like studies where they've done brain scans of people with trauma histories, and what they actually see is that like at the neurological level, people tend to perceive and interpret danger when there's just like someone approaching them. They have just like a person walking toward them, and their brain is like alerting them that this is danger rather than like an opportunity for connection. So people who've experienced trauma tend to skew in different ways around safety and danger that increase the likelihood of re-traumatization, but also increase the likelihood that they're going to be isolated and disconnected from people who may be really useful supports for them. So the way that people typically respond when folks disclose that they have some kind of trauma history or that they are struggling with their substance use often makes it less likely for people to want to keep talking about it. And then we see where people feel like kind of hopeless around the idea that it might actually be helpful and useful to seek out support. Certainly things like victim blaming and shaming contribute to this. People hear a lot of judgment, shoulding, telling people what they should do. But I think even just shock of people having that type of reaction to people's disclosures really creates this sense of disconnection and makes people feel sort of othered, like they're separate from people. We also know that trauma unfolds within the context of relationships. So certainly interpersonal trauma really betrays people's willingness to trust other people or even to trust their own instincts about other people, which makes it really hard for folks then to establish and maintain healthy relationships, which are also really essential in mitigating the effects of trauma. So healthy relationships are what allow us to feel more regulated. So all self-regulation begins as co-regulation. We learn to do that within a relationship, and then we are able to do that within ourselves. Any parent, like an infant, can kind of see that play out in real time, right? And so people are less likely to be able to soothe and heal themselves if they don't have healthy relationships that can offer that type of co-regulation. And so we see people continue to remain more dysregulated. The other thing is that, like, the goal isn't for people to just survive entirely on their own, separate from other people. We want them to be able to maintain connection with other people and feel soothed and comforted by their relationships and have relationships be a source of trust and connection. That is kind of the context of healing from trauma. So we see that, like, relationships are significantly impacted. Trauma symptoms themselves include the sense of depersonalization and derealization. So the feeling of, like, I'm just different from other people now, and no one really understands me, and I don't understand them. Derealization also kind of takes the form of, like, I've talked with people who feel like they're going through life as if they're watching themselves live their lives rather than actually living it. And this disconnection from yourself, then we can understand, makes it really hard for people to form authentic connections with others, which again contributes to their sense of isolation. And so when people are less isolated and less likely to engage, they're not as likely to have access to the supports that are out there, either in their personal network, but also with service providers. So we see decreased access to healthcare, and sometimes, that also means less information and resources that could help keep someone safe. As far as, like, more likely to use substances alone, we also know that that increases someone's risk of overdose and other substance-related harms. So having other people around is a really protective factor, and unfortunately, a lot of the symptoms of trauma and substance use and kind of the ways that those interact tend to keep people more isolated. And so we see this cyclical pattern of substance use and trauma being risk factors for each other, and then also exacerbating the challenges of both. So knowing that these two things are so interconnected, it really makes sense to treat them together, which highlights, like I said at the beginning, the need for integrated care. But unfortunately, that's not really what we see very often in practice. So some of the approaches that have been historically used in substance use treatment are effective for some people, which is why they've been used, but they're not effective for all. And unfortunately, people who have significant trauma histories tend to fall into that latter category. So approaches that really emphasize an abstinence-focused goal or champion abstinence as the only acceptable goal really overlook the trauma-related needs that folks present with. So even though substance use can exacerbate some trauma symptoms, it isn't necessarily the case that abstinence automatically resolves them, which is a little counterintuitive, but also makes sense when we look a little more carefully at the dynamics there. So in some instances, people's trauma symptoms are actually more pronounced when they're abstinent. The substance use was pretty effective to some degree in managing the trauma symptoms. And I would say the field in general, I think, is doing a really great job of moving away from more confrontational approaches, because we know that that's generally not the most effective way to support anyone in making any kind of meaningful and lasting change. But for folks who have experienced trauma, this style and approach can really inadvertently mirror and recreate some of the dynamics of traumatic events where people feel powerless and without control, and a great sense of shame. And so then we see where that type of confrontational style can actually heighten some of the depressive and anxious symptoms that are so frequently associated with people who've experienced trauma. 12-step self-help groups have been really helpful for some people, which is why they're so often recommended as kind of like an add-on to formal treatment. But the difficulty with any kind of peer-led group is that it's unregulated because it's peer-led. You don't have to have any type of particular training or experience or fidelity to a model to run a peer-led group. And so even though 12-step models aren't inherently opposed to pharmacological interventions, things like medication-assisted interventions, anecdotally and in practice, there are many people who attend 12-step groups that receive the message that it's not okay to use buprenorphine or antidepressants, that you're replacing one drug for another. And 12-step models don't have any kind of mechanism built in to address the impact of trauma. And for some folks, they can experience that as being very shame-based in the messaging. And then kind of on the flip side, we also see that treatments that are effective for PTSD, like exposure-based approaches, as well as some others that we'll talk about in a little bit, they aren't necessarily equipped for addressing substance use either. So all of this really, again, highlights the need for integrated and trauma-informed substance use treatment. So trauma-informed care has become a buzzword in the last little bit of time here, which is great in that it's like in the public consciousness and people are talking about it and thinking about it. but I don't know that we always agree on like what we mean when we say that we're trauma informed. And I think right now, substance use treatment programs and many programs are really striving to be trauma informed. We recognize that these are values and principles that are really important to embrace, but sometimes really struggle with like, how do we put this into practice? And like, what does this really look like, especially in the context of substance use treatment? So as we talk through this definition on the slide, it might be helpful to think about like with your program and your organization, or even more broadly, like the system of substance use treatment in general. What are we doing well to be trauma informed, and where is there room for growth? So this definition comes from SAMHSA, and they talk about the 4 R's. So the first is, in order to be trauma informed, a program or organization or system realizes the widespread impact of trauma and understands potential paths for recovery. So you all really referenced this in the poll, right? You are aware that the vast majority of people who are entering your program have experienced some type of trauma. So we want to assume universal exposure to some amount of trauma. And to recognize that the people who enter our programs are very, very likely to have been exposed to a considerable amount of trauma. And that's because of like what we know about how closely trauma and substance use are connected. So do we ask about trauma? Do we screen for it? Are staff knowledgeable about the ways that trauma affects folks and how they recover from it as well? And do we have an understanding about how trauma is really interwoven into people's relationships with drugs? The second R is recognize it. No one comes through our doors saying, I'm really struggling with alarm fatigue. So how do we recognize it when we see it? What are some of the signs and symptoms that we would look for? And then I think more importantly, are we able to really view people's behaviors through a trauma lens? And this requires us to both know about trauma symptoms, but also to really look beyond the surface and be curious about people's behaviors and kind of give up some of our expert lens and be willing to wonder and not know when we see people engaging in certain behaviors, like what is driving that behavior, and can we be curious about that and try and wonder with them about what role trauma might play. The third R is, it's not enough to like know it's out there and be able to recognize it. We have to then be able to respond at all levels within the program or organization. And again, we'll talk about this more, but there's sometimes this idea that like trauma-informed care only applies to frontline staff who are working directly with folks. And that couldn't be further from the truth. Trauma-informed care is something that really has to be, I think, led from leadership and as a top-down kind of approach where we have a system in place and our policies and procedures and the way that we hire and onboard and develop our policies about how we work with people are taking our knowledge about trauma into account and being really thoughtful. And then certainly last but not least is that in order to be trauma informed, we have to be active in and proactive in resisting re-traumatization, because we understand that there's such a high risk for re-traumatization, and we're being really, like I said, proactive about trying to avoid that for the individuals and communities being served, as well as for the staff in the program. So all of this applies to the people who work in these programs as well. And so I would say that trauma-informed care is something that we really strive for. I don't know that it's something we necessarily achieve. And striving to be trauma-informed really requires us to take inventory and make changes and then reassess. And that can be uncomfortable. And it definitely requires a lot of resources and an investment. And so I think especially these days, everyone wants to say that they're trauma-informed, but the reality is it's really hard to do. And it requires an ongoing commitment. Like I said, including a willingness to acknowledge when we need to make some changes. So we've talked a good amount about the first R of realizing the widespread impact of trauma. And we're going to talk a little bit on the next couple slides about the second R of how do we recognize when people we're working with may have experienced trauma. And so this comes from DSM-5. This is the criteria for post-traumatic stress disorder. And they talk about 4 categories or clusters of symptoms. So the first is re-experiencing. And this is where people have things like flashbacks or nightmares or involuntary memories or thoughts where they find themselves kind of thinking about the traumatic event when they don't necessarily want to be. The next cluster of symptoms is avoidance, where people are really trying not to think about the thoughts, feelings, people, places, things that are associated with the event. And in the extreme, we see dissociation, where people are just not present. The third symptom cluster is a negative change in mood and thoughts. So we see people feeling a lot of guilt and shame, feeling like they somehow should have been able to stop this thing from happening. We hear some exaggerated negative beliefs. So things like the world is just a totally unsafe place and I can't trust anybody. We also see a lot of depression is really strongly associated with trauma histories and feeling kind of detached from yourself or others. And then the fourth symptom cluster is what we call change in arousal and reactivity. And this is speaking mostly at a physiological level. So people have a hard time kind of regulating their body. So they're either feeling wound up and on edge, where we see what's called the exaggerated startle response, where people are like very jumpy and hypervigilant. We also see aggressive outbursts where it doesn't take a lot to kind of put people over the edge. This is where we also see a lot of people have a lot of difficulty with like eating, sleeping, concentrating, but it's hard for them to kind of like get to a good balanced place. It becomes PTSD when this lasts for more than a month, when a certain number of these symptoms together occur for more than a month and interrupts functioning. So I think a lot of us also thinking in terms of like vicarious trauma, right? We've probably experienced this as it pertains to work or things in our personal lives. It doesn't mean that we all have PTSD. It means that we have a really normal reaction to trauma exposure, which is also, I think another way to think about PTSD is I like to think of it as more of a post-traumatic injury rather than a disorder. It is a response to the traumatic event itself. So I think the DSM gives us like a good starting place, but there's a lot more nuance to people's experiences and expressions of trauma. So we want to be able to like broaden our scope of what we recognize as trauma. And trauma really at its core involves loss at a lot of different levels. So we see this loss of a sense of safety, and we've talked about the loss of danger cues and trust. Shame is a big piece of it. We see loss of intimacy both within friendships, but also in terms of someone's sexual activity, especially if they're survivors of sexual abuse. We certainly see dissociation, where people kind of lose the ability to be present, where the best way to cope with what was happening was to go away and not be present. But that strategy later in a different context is sometimes not helpful to folks or can feel overwhelming. We also see a loss of connection to the physical body. So where people are no longer able to really trust their bodily cues and the things that happen in their body, like having a fast heart rate, which happens to all of us at different times for a lot of different reasons, becomes interpreted through a trauma lens, and then can become itself triggering for people. And so it can be really hard for trauma survivors to be attuned to what's happening at the physical level with their body. There's certainly a loss of sense of self, where people feel like their identity is now defined by their experiences of trauma. And that's also closely tied to loss of self-worth, where people, especially children, but I would say of any age, people who experience trauma often feel like I'm like bad or dirty, or like marked in some way. I worked with someone who was really heartbreaking, but he always described himself as being a dented can, that he, was like one of those cans at the grocery store that's just dented and it's just not very good. And that's unfortunately something that we see very commonly. And then we see what's called here reenactment, which is someone tending to like engage in the same types of behaviors that initially led to their traumatic experience. So I think my hope in sharing this information is just that we are more able to think about different ways that trauma may show up in some of the people that we work with, so that when we see different behaviors, we're able to kind of tie them to people's histories of trauma. So I would say the 4 R's that we talked about a few minutes ago are kind of like the definition of what is trauma-informed care. And these key principles also come from SAMHSA. And this is more of like the how, like how do we practice trauma-informed care? So there's got to be an emphasis on safety. I would say we've talked about safety a lot, and that's because you have to talk and think very clearly and proactively and in layered ways about safety when you're working with people who've experienced trauma. Building trust is a really important part, and a big part of that is being transparent. So letting people know why we're doing the things we're doing, letting them know what comes next. So as far as like treatment programs, sometimes I think some like examples of this is in our policies, of being transparent about what our policies are, why they are in place, and also, within the organization, being willing to like review and maybe update our policies if they aren't particularly trauma informed. Peer support is really crucial. So we know that we as service providers have a particular skill set and relationship with the people we serve that has the power to be really transformative and healing. And that's just really different than relating to someone on a peer level. That layer of power and just that different power dynamic really alters people's experience of relationships. We've also talked a lot about how trauma tends to lead to so much isolation. And so it's really important to have that sense of peer support and connection where people can hear from other people. It's not just me, and other people have gone through some similar experiences and responded in maybe similar ways. I also think it's really helpful for people who are struggling to feel helpful to other people. It's really amazing when you see the way that can boost people's sense of confidence. Collaboration mutuality means that we are not doing services to the people that we provide. We are collaborating with them and being active in seeking out their input, and that they have a sense of power, which speaks to kind of the next bullet point, empowerment, voice, and choice, that we're hearing from them what they want. We're really centering their voices and preferences for treatment, rather than making decisions more unilaterally. We also really need to be taking into account historical, cultural, and gender issues and context, right? That trauma doesn't occur in a vacuum, and are we working with someone who comes from a historically or presently marginalized group, and what is the context around accessing treatment services within their cultural community, and how can we demonstrate cultural humility in working with them? So as far as like who is trauma-informed care for, it's everyone. It's something that we do at all levels of an organization or a program, regardless of your role. Who should provide trauma therapy? Only trained clinicians. So trauma-informed care is like our overarching approach. It's not the same as trauma therapy. So even people who are not trained in things like trauma-specific treatments, so things like somatic experiencing or EMDR, different CBT approaches, even if you're not trained in those, folks can and really need to incorporate principles of trauma-informed care into their approach. But we also want to be careful of recognizing the limitations and really honoring the limits of our training and expertise. So like I said, trauma-informed systems and services really take into account knowledge about trauma. It's literally what it means, trauma-informed, and that we're using our information about trauma to inform our systems of care. And that knowledge is really thoroughly incorporated into all aspects of a program. That's different than trauma-specific services, which are more focused. So those are services that are directly addressing the impact of trauma on people's lives and really working with folks to facilitate recovery and healing. So trauma resolution for many individuals will require trauma-specific treatment. And kind of what that looks like and what that is really far beyond the scope of today's presentation. I would say, if people are going to do trauma-specific work, it's really important that they have training in it. And I want to really make clear that everyone plays an important role in trauma-informed care. And just because something isn't therapy doesn't mean that it's not therapeutic. So I think, why don't we go ahead and take our break here, and we'll come back and kind of talk a little bit more about integrated care and what that looks like. I guess before we take our break, are there any questions that have come up that would be helpful to address before we go on our break? Okay, I'm going to take that as a no. Rebecca, feel free to let me know if there are any questions that you've seen come in. But let's go ahead and take our 5-minute break. So it's 11 o'clock on the dot, and we'll come back at 11:05.
Hey, and Susie, there are no questions in the chat at this time.
Great, thank you.
everyone. I'd like to welcome you back. We're going to start back now. Our 5-minute intermission is over.
Okay, welcome back, everyone. So we've talked a lot about kind of the need for integrated care. So so it's a big topic. we're not going to fully cover what integrated care looks like, but one of the things that I find to be helpful as like a good starting place to rest our focus is on these 3 areas of safety, control, and connection in terms of being effective in working with people who've experienced trauma and working with people with a substance use disorder. These are 3 areas where there's a lot of overlap, and that we can really focus. And if we're focused on safety, control, and connection, that's a good starting place for integrated care. So we'll kind of go through them in a little more detail. So I like to think about safety along multiple dimensions. So internal safety refers to someone's ability to really regulate and tolerate their own emotional experiences and their physiological experiences. Just, does this person feel safe with themselves inside their body? Relational safety is kind of asking, do you have a good enough caregiving system? Doesn't have to be the absolute best, but is it good enough? Meaning there's a consistent response, safe limits, appropriate praise and reinforcement, definitely having a sense of predictability and appropriate boundaries would be important components of relational safety. Physiological safety thinks about this idea kind of as like our body is an animal. Is our animal body safe? Does it have food, medical care? Are we free from self-injury? Are we able to access and utilize medical support? But just as our body physically having its needs met. Environmental safety refers to the physical environment around someone, so their neighborhood is the physical environment of their home, their treatment program, their community. Does that feel safe? And is it kind of structured in a way to support their regulation and recovery? Therapeutic safety refers to a sense of safety with us. Is there a sense of trust? Do we have a good therapeutic alliance in place, safe boundaries? Do they experience us and our treatment program as being a supportive and affirming environment? And then is there agency and system level safety? So is our organization trauma informed in its policies and procedures? Do we have staff orientation and training and support? Are there protocols in place for critical incidents to support both staff and people receiving services? Is there ongoing supervision, things in place to support people's management of vicarious trauma? So I say all this to say that, safety is subjective and it's multidimensional. So no one is going to experience 100% sense of felt safety in all of these areas at the same time, all the time, no matter what. So the question is sort of like, where is this, in what dimensions is this person feeling pretty safe, and where are there opportunities for support? So, for example, I've worked with a lot of folks who live in communities that are not particularly safe, where there's a lot of community violence that occurs, and there's not a whole lot that I and my participants felt like we could really do to increase their sense of environmental safety. And so that then kind of prompted us to turn to some of these other dimensions and what are some other dimensions where we can increase this person's sense of safety. So I think thinking about safety in this multidimensional way also opens up our options for how we can support and intervene. I also think it's worth pointing out and talking about safety and substance use, and that it's really important for us as providers to offer and provide really balanced, transparent, and neutral information about our treatment services. I think one of the biggest things that isn't always clear to folks is what are the conditions for discharge? What do I have to do to get in the door and then stay in the door? What are the things that are going to lead to an administrative discharge? What kind of policies are in place? What are your expectations of me? But, and those of you who've been in previous trainings will know that I'm definitely a harm reductionist and advocate a harm reduction approach. And so I think we also keep people safer when we offer them information about strategies and resources for safer use. And to give people information about withdrawal and tolerance and overdose risk factors, I can't tell you how many people I've worked with who are, daily heroin users who don't necessarily know a whole lot about withdrawal and tolerance, or they know some of the overdose risk factors, but there are actually some risk factors that they weren't aware of that they may be able to mitigate in some ways, and that absolutely keeps them safer. I think offering naloxone and overdose education is also a big part of this. We want to keep people as safe as possible. And then offering medication-assisted treatment, I think is another strategy that we can use to increase people's sense of safety. I really like this quote that says, "We should make great efforts to do nothing that could be re-traumatizing, such as exercising authority and/or control, asking intrusive questions, being unpredictable, or using shaming language or techniques." So certainly people can't feel safe if they're being re-traumatized. And I'm also certain that there's no one here today who wants to be re-traumatizing to the people that they serve. But I don't know that we always think about re-traumatization in these terms. I think thinking through the dynamics that are so present for people's experiences of trauma, it is really helpful to make this link that these are some of the behaviors that could increase someone's risk of re-traumatization and that we want to be really mindful of for people's sense of therapeutic safety with us.
And Susie, we have two questions from the chat. Is this a good time to bring those up?
Absolutely.
Okay. Someone asks, how do we talk to clients and increase buy-in around trauma? I work in a program that treats men with SUD and criminal justice, and many of them come from backgrounds of complex trauma. However, I experience a lot of resistance when trying to discuss trauma and the impact it has on their SUD and overall functions. Do you have any recommendations?
That is a fantastic question. I'm so glad it was asked. So thank you, whoever asked that question, because I'm sure you're not the only person who is thinking about it. One of the important things that I don't think I've said that this question really prompts is it's not our job to convince people that they have experienced trauma. So part of being trauma informed is us being able to recognize trauma and to be able to see the dynamics and how that might be connected to someone's substance use. But we don't need to convince people that they have experienced trauma in order to be trauma informed. So as far as working with people who, I'm kind of looking back through the slides here, because I think this is part of where we want to go. I think this is where we really want to emphasize that collaboration and mutuality and empowerment, voice and choice. For especially in our culture, for men who've experienced complex trauma, there are certainly some cultural, historical, and gender issues there that contribute to men not wanting necessarily to identify themselves as trauma survivors, that doesn't feel particularly empowering. And so I think where we can begin is always with like safety and containment as a good place to start, of like what helps them feel safe, how do they build a sense of safety along those different dimensions that we discussed. And then as far as like voice and choice, what is important to them that they want to be working on? And for most people, which is why I'm so glad you asked this question, most people aren't going to say my trauma history, right? It might be my sleep, my relationships, my job, my, some of the other ways that substance use affects me. And so trauma and all of our knowledge about it are things that we want to be really well versed in, but we absolutely don't want to try and convince someone this is because of your trauma, right? We want to be able to support them with our knowledge of trauma and being able to manage and regulate some of the effects of it. But that doesn't require that someone necessarily identifies that they have experienced trauma, if that makes sense.
And then the next question, Susie, was if you wouldn't mind to provide an example or hypothetical scenario for how to do an apology if there is re-traumatization.
Another excellent question. And I love that you're asking about apologies, because I think in general, I had a supervisor who said apologies are free. And we tend to work in a field with limited resources where we never have enough funding or time, but it doesn't cost us anything to apologize. So I think it depends on the circumstance, but I think being able to just say, if we maybe exercised authority or control and really pushed someone to make a decision that we thought was in their best interest, but was clearly not what they wanted to do, I think being able to just catch ourselves and say, I'm realizing that the last time we met, I really was sort of pushing you in this direction. And although that came from a good place in thinking about it, I realized that wasn't particularly respectful or helpful. And you know what's best for you way more than I do. And I really do trust and believe that. And I'm sorry that I didn't show that to you that day. Here's how I think we can move forward. And some people might want to talk about that more and have more information about what you're going to be doing differently. And I think other people will trust that when you show them.
And that's all the questions for now, Susie.
Okay. Excellent questions. All right, so we've talked about safety, control, and connection were our other ones. So as far as control, and this I kind of just touched on, but we want to be very clear about putting people in positions of control within their own lives. That's a really trauma-informed practice, because trauma is so much about not being able to choose what happens to you, and that is traumatic. So the ability and skill of being able to identify and respond to your own needs and preferences is a really essential component of trauma recovery. So we want to really emphasize autonomy. There's a trap that people will lure us into where they'll say, well, what do you think I should do? Tell me. And it's so tempting for us to jump in and be like, I'm so glad you asked. I've been waiting, and here I am, ready to tell you what to do. And I think we need to catch ourselves in those moments and be able to say, I so understand wanting an answer. And I have some ideas, but I really think I can't answer this for you. What I can do is talk through what your different options are and weigh them with you, because you know much better than I do what's going on in your life and what might be effective. We talked about this earlier as far as like reframing risky behaviors as an attempt to take some type of control, but it's a way that people try and do something or have some type of choice. So we want to really understand how those behaviors might have been helpful to someone in the past, and then help support them in finding a new strategy to meet that need. And we meet people typically at the point that that behavior might not be providing relief to them anymore, or it's providing relief but a whole slew of other complicating factors. But we also have to really honor that at some point this was helpful to the person. So for example, I worked many years with people experiencing homelessness, and a lot of folks would like hide important documents. And when you're homeless, that sort of makes sense, because just having everything that's important on your body with you at all times is pretty risky. And so stashing things in different places might be helpful and relatively benign, but can later become pretty problematic in a different context. So when we see people engaging in risky behaviors, we need to remind ourselves that we're seeing them now in a different context than when this behavior originated. We want to be really proactive about identifying and protecting people's rights and services. So that is one of the ways that they have control in our program. So really being able to elicit feedback from them. I always let people know, you have the right to complain, and you have the right to tell me that you don't like my ideas. Like, I can't make you do anything, and this is how we improve our programs. If there's something that's not working for you, it's really actually helpful for us if you let me know, because usually what happens is either people disappear, and that's not benefiting them, but it's also not improving our program, or they just stay quiet about it. And again, that's not helping them or helping our program. So really eliciting people's feedback. And I think that also goes with like asking permission. We want to ask people permission to give them feedback or offer solutions, or even in some instances to engage. So again, as an outreach worker, we would always ask, would it be okay if I talk to you for a minute? And then we want to offer people choices whenever possible. So things like, where would you like to sit? Do you prefer to meet in the morning or afternoon? You know, when do you want to meet next? So we want to be as proactive as we can about giving people control. So we're going to watch a short video. So Rebecca, if you want to start getting that pulled up. And this really offers us a reframe on how we think about addiction, and it infuses some of the ideas of trauma-informed care into it, and really gets at the idea that a lack of connection is at the heart of trauma and at the heart of addiction. So we'll take a look. All right. So I like that video because I think it helps us think about the importance of connection in terms of recovery, but also to think about, I like the way it reframes recovery as being less of an individual issue and more prompting us to think about social recovery and how can we increase connection, because there are some folks who may turn to drug use in order to manage their sense of disconnection. But I think a lot of folks really struggle with the sense of isolation, particularly in the last year. And it's an important thing for us to think about regardless of whether someone is struggling to manage it in terms of drug use or in other ways. And yes, I see Robin saying how we recover from this past year will be interesting. Absolutely. And I think, you know, to our credit, we have been pretty creative in trying to find ways to maintain connection. And I think one of the things I have heard from a lot of different groups I've worked with, as well as just people in my personal life, is that the past year has really highlighted the importance of connection. And being so isolated and disconnected, I think, has reminded so many of us that connection plays a really important role. It's not just kind of a bonus in our lives, but it has a lot of really important functions. So, as far as working with people in our programs, we really want to focus on engagement. It's the foundation of everything else. If we don't have a relationship with a person in our program, we really can't do anything else. So we have to focus on that therapeutic alliance. And the more engaged people are, the more likely they are to make positive changes, to be safer, to have better health outcomes. And we know that being seen and accepted is healing in itself. We talked earlier about the idea that healing takes place in the context of health and connection. The goal isn't for people to just, you know, be isolated on their own, but manage their substance use. The goal is for people to have really corrective emotional experiences within healthy relationships. And I think this speaks exactly to the video of, you know, the idea that the opposite of addiction isn't sobriety, it's connection. We also know that people are safer in communities. So when people have people that they can talk through decisions with, they're safer. And that's also, I think, an important part of people accessing services and just knowing what's out there. I like this quote from Basil van der Kolk. He says, being able to feel safe with other people is probably the single most important aspect of mental health. Safe connections are fundamental to meaningful and satisfying lives. So there are some strategies that we'll talk through now about how we can integrate treatment. And these aren't necessarily specific strategies, but more kind of like principles. So it's really important in a substance use treatment program to be able to recognize that trauma is a defining and organizing experience. We know that for people who are experiencing severe substance use disorder, that their substance use becomes a defining and organizing experience, and we want to recognize the role of trauma as well. We need to be proactive about being collaborative in ways that prioritize people's safety, choice, and control. We want to understand the multiple and layered interactions between substance use and complex trauma. And we want to be able to simultaneously address these two issues. So in the past, more so than now, there's been some debate about, like, first you address the trauma and then you address the substance use, or first you address the substance use and then the trauma. And we know that neither of those are effective because the two are interwoven and connected to each other. So we need to be able to address them as one. We also, again, this will sound familiar, need to be really clear about how we empower people to engage in making collaborative decisions during all phases of treatment. So again, this isn't us telling people what to do and how to do it, but really collaborating alongside them. And then we also want to have ancillary services available and really implement and access them so that we're treating the whole person and working with them in a more holistic manner. So I mentioned that my husband works in this field as well. And so on our bookshelf at home, we have a lot of books that talk about substance use and trauma. And so I did kind of a quick scan of our bookshelf and thought about, you know, if I were looking for references about relapse prevention, like what would I pick up just of the things that we happen to have at home? And these were the 4 books that I picked out. And I thought it was interesting. I looked through each of these 4 books and I looked in the index in the back to see how much do they talk about trauma. And so the first one, Treating Addictive Behaviors, comes from 1998, so it's pretty old. And in 350 pages, it has 0 mentions of trauma or PTSD. Relapse prevention, or I'll go in order here. Harm reduction, psychotherapy. Again, a book that I really like and have recommended to many people. Comes from the year 2000. It has 1 brief section on trauma and the neurobiological aspects of it. And out of a 200-page book, it's 3 pages long. And it acknowledges that, you know, talking about the neurobiological aspects of trauma is beyond the scope of the book, but has no integrated discussion about, like, what does that mean for treatment. Relapse prevention from 2005 is almost 400 pages long. It has 0 mentions of trauma and 1 mention of PTSD, which I looked, and it's in a section on gambling disorders, and it's questioning whether other anxiety disorders are comorbid with pathological gambling. So again, definitely no integrated discussion around how do you take trauma into account when talking about relapse prevention for 400 pages. And then this last one, harm reduction page, is from 2012, also almost 400 pages long. And it has 2 really brief mentions of PTSD and 2 mentions of trauma, talking about the brain. And again, I looked at them, and one is 3 paragraphs about the neurobiology of trauma, and then 1 sentence about how exposure to trauma changes brain chemistry. So I say this not to, like, pick on these books, because I like these books and I think they're really helpful, but there's just not a lot of integration in the field about how do we address substance use disorders and what does relapse prevention look like with, like, an integration of trauma, knowing that that is so common for folks. And so we really need to be creative in how we integrate trauma-informed care into relapse prevention. So where we're going to finish up is looking at a couple of sources. So Seeking Safety is a manualized treatment. And this is the one reference that I know of, or materials that I know of, that is specifically designed for people who've experienced both PTSD and substance use disorder. And this uses a CBT approach with some adaptations, and it has 25 topics and just like different materials about each of these topics. So what I have here is material from their chapter on coping with triggers, because this is such a common thing that we talk about in relapse prevention. is being able to cope with triggers. And so this is the list of triggers that they offer in the book. And so they kind of divide them into substance use and trauma. They don't provide this list to group members, but these are the common triggers that are listed in the manual. And this is from the manual. This is the material. So they talk about fighting the good fight, and kind of talk about what triggers are, emphasize staying away from triggers, really advise people not to test themselves with triggers, to acknowledge that triggers are part of life, but you can, quote, fight the good fight, strive for balance, and acknowledging that triggers can be sudden. And so this is kind of what they offer as far as the ways to cope with triggers, is to change the who, what, and where. So who you're with, what you're doing, and where you are, and to really just try and avoid triggers and put as much space between you and that trigger as possible in order to create a safety zone. So what I recommend is to really think about how trauma-informed is this. And I think this, I'm not trying to pick on seeking safety. I think it has some really useful material. But I think in general, there aren't enough sources for integrated care. And then the sources that do recognize the role of trauma and substance use tend to oversimplify it and offer a lot of platitudes, which I think really just highlights the need for more nuanced understanding and approaches. And, looking back at this list of triggers, like if you're triggered by a time of day or a season or a child crying and you're a parent, like how are you supposed to avoid these things? And so manualized approaches are really helpful. And there's definitely, these are evidence-based, so there's evidence that they can make a positive difference. But I share this to say we also need to use our clinical skills and our critical thinking and our more personalized knowledge of individual clients in order to adapt material to best fit them. So effectively addressing the intersection of trauma and substance use is really complicated and requires a complicated skill set in thinking. So I also want to share another example. So this comes from mindfulness-based sobriety, which is something that I used at the treatment program I worked at. And in general, I really like this approach. It's a group curricula, and it is kind of an integration of 3 approaches. So it integrates relapse prevention therapy, acceptance and commitment therapy, and motivational interviewing. And it's really focused on enhancing awareness, accepting experiences, and clarifying values. So I'm going to walk us through an activity that they offer for urge surfing, which is, again, another really common relapse prevention skill. And I would encourage you to consider this exercise through the lens of trauma-informed care and to think about what would work well and what might be a challenge for someone who's experienced trauma. So the directions are to sit comfortably in a chair or on a pillow with your back relatively straight, and if that's not comfortable, you may lie down. Close your eyes. Focus your attention for a few minutes on your breathing. Now think of a type of situation in which you might feel an urge to react impulsively, such as with substance use or an angry outburst. Select a situation that is challenging, but not one that is overwhelming. The purpose of the exercise is to experience and observe the urge to react while not reacting, to have a gentle and curious approach. You may select the type of situation you've experienced in the past, one in which you have experienced cravings or urges to do something that is inconsistent with your values and goals. So go ahead and select a situation. It's important to note that some of you may not experience an actual urge or craving during this exercise, which is not uncommon. Please attempt to follow the exercise as best you can and use it as a practice round for real life experiences. Imagine that you are in that situation and that you do not engage in the reactive behavior. If in the course of this exercise, the situation begins to feel overwhelming, pick a less challenging situation. If the situation is overwhelming, you may open your eyes for a while, move around in your seat, and focus on your immediate sensations, such as the feeling of your body sitting in the chair or your feet on the floor, sounds in the room, and so on. You may close your eyes again as you feel more comfortable. And now the exercise will begin. In your mind's eye, picture the challenging situation. I'll give you a minute or two of silence while you imagine the situation. You may notice thoughts, emotions, or physical sensations that come and go. If cravings or urges occur, just observe them. Notice how the cravings and urges are like waves. They rise, they crest, and they fall. This pattern continues. Stay with the experience. Observe the waves. Even though you're not reacting, the cravings and urges fall. They subside. They may rise again and subside again. You are like a surfer riding the waves. You may enjoy the freedom of observing while not needing to react. Some cravings and urges are more intense than others. Some are like small waves, while others are more like ocean or tidal waves. Notice that you can be present and not react, that you can experience cravings and urges and not react. Now you may let go of the scenario and return your attention to the breathing. Open your eyes if they were closed and bring your attention back to the room. So this activity would typically take about 15 to 20 minutes of having people just focus on their experience of feeling these waves come and go and encouraging them to just pay close attention to them and not react. And then it would conclude with kind of processing the group's experience. So I'm curious to hear from you all, just hearing that instruction and thinking about it briefly, what components of that do you think worked well? And please go ahead and enter your responses into the chat. And when I say work well, I mean through a trauma-informed lens. Yeah, so being calm and relaxed, giving people a sense of control over their experience with cravings, seeing yourself make a different choice, the correlation to the waves, they're always there, but not at the same intensity. Suggestion, absolutely, of grounding techniques. If someone was triggered, I think that was extremely trauma-informed, being able to breathe. Yeah. So there's a lot here that this activity does well that I think is pretty trauma-informed, and being able to teach relapse prevention skills in an integrated manner. But what kind of concerns do you have from a trauma lens? What about this exercise might be challenging for someone who has experienced a history of trauma? So asking people to close their eyes, like a good suggestion or adaptation would be inviting people and offering them the choice. But sitting through the feelings and emotions, for some people, if what comes up and the wave that they're riding is a flashback, that's going to be really upsetting for them and very triggering. It's possible this could trigger a client to engage in adverse behavior. Yep. People might have flashbacks of their past. They might see trauma behind their closed eyes. Sitting with your eyes shut while being unable to ground yourself could be difficult. Having this be done in a group setting could stir up trust issues. So there's some concerns that I'm so glad to hear you all thinking about, because I think this is really where the work, this is kind of where the rubber hits the road, right? Is how do we take our understanding of trauma-informed care and apply it in real life settings? And so I would encourage you to consider, and feel free to enter into the chat, what changes you might implement in order to make this activity more trauma-informed. Because I think, again, while manualized approaches are really helpful and give us a good starting point, this manual wasn't designed for the specific people in your program, but you are the person who knows the folks in your program. And so the question here is, how would the clinician prepare the client for this type of exercise? So again, we want to be thoughtful about asking someone to close their eyes if that makes them unsafe. So the alternative suggestion that I always offer, rather than close your eyes, is, or just have a soft gaze in front of you, in case that feels more comfortable for people to leave their eyes open, but just, you know, kind of focus softly on a space. Lower your gaze. Having people record their directions themselves so they know what's coming. I see Claire suggested that. Another similar adaptation would be to maybe provide people the directions written, because we also know different people learn in different ways. Asking permission. I think another good adaptation here would be some more preparation ahead of time around what activity to choose or what urge to choose. I think saying, you know, don't choose the most challenging thing is a helpful instruction, but for making it more trauma-informed, I think we want to be a little more specific with people, and maybe even building off some of your suggestions of letting them know what we're going to do so that they can then choose something that it would be safe to sit with, because not all experiences for trauma survivors are safe to just sit with and watch. There's some things where to be encouraged to just sit and watch something unfold and not respond might actually be really harmful for someone. So thank you all so much for these really amazing responses, and it's really exciting to see all the different ways that you're being thoughtful about how to integrate some of this. And that's kind of where I want to end, is just by saying that a lot of the work to integrate trauma-informed responses into relapse prevention and into substance use treatment in general is hard work that we're going to have to do. We're going to have to find and really vet the resources that we offer to people and to seek out trauma-informed approaches, but then also really use our critical thinking skills to integrate that information into how we do things. We're going to have to reassess our current materials and think about what needs changing. The field of trauma studies is really quickly evolving, right? We know so much more than we did 5, 10, certainly 20 years ago, which is when a lot of our resources came from, because as far as substance use treatment, they may still be really useful resources for us to use, but we're going to have to be creative and thoughtful about how we adapt them to the people in our programs. And like I said, this field of trauma studies changes very quickly, and so the onus is on us to really keep up with the times and continue to learn and adapt. And that requires us to get comfortable with being somewhat uncomfortable. We're not going to be able to sit in this place of knowing and feeling fully confident with what we're doing. We're going to have to be willing to question what we're doing and to kind of reassess on an ongoing basis. And like I said here, to really commit to our ongoing growth. So as I wrap up, I have just a couple questions for you to consider to yourselves of what are you already doing well that you want to make sure to continue doing? What's the most important thing that you learned today? And what is one specific change that you want to make moving forward? So thank you all for your time and for all that you do. And I will turn it over to Rebecca to wrap things up.
I'm sorry. I'm going to start over. We had a technical issue. Unfortunately, this is all the time we have today. We have included Susie's contact information so that you may contact her with any further questions. Susie, we really appreciate and thank you for all the work you put into this webinar and all the valuable information you shared with us today. We are sure this training will help practitioners better serve those struggling with the disease of addiction. Please note a couple of items of business before we conclude. When I conclude today's webinar, your browser will take you to an evaluation on FATA's new website. If you want to receive CE credits or a statement of credit for this event, please complete the evaluation. You will be prompted to register or sign in to complete the evaluation. You can register as a visitor at no cost. For CEs to be reported to CE broker for Florida licensed healthcare practitioners, you must provide an accurate Florida Department of Health license prefix and number the first time you register. After you register or sign in, you will be directed onward to the evaluation. You may consider using the same email address when you register for webinars through our WebEx link and when you set up your profile in FATA system. This helps connect your attendance and your profile. You will get a second opportunity to complete the evaluation through a follow-up email later today in about 30 minutes. The sender will be messenger at WebEx. The evaluation will close at midnight on Monday, April the 12th, 2021. We do not email statements of credit. Instead, after we verify attendance and complete the evaluation, a statement of credit will be generated as a journal entry within your profile. Thank you for participating in today's webinar. We'd also like to recognize and thank especially the Florida Department of Children and Families, Office of Substance Abuse and Mental Health for funding today's education. Have a great rest of your day and please hold for the evaluation.